14 to 18 mm of Hg at rest, 20 to 25 mm of Hg on exercise. Hemodynamically, it is defined as an increase in mean pulmonary arterial pressure more than 25 mm of Hg at rest, can be measured by right heart catheterization. Two definitions of pulmonary hypertension that were previously accepted are no longer used. Mean pulmonary artery pressure more than 30 mm of Hg with exercise. Estimated systolic pulmonary artery pressure more than 40 mm of Hg estimated by the Doppler echocardiography, and before that was right heart catheterizations. Hemodynamically definition for pulmonary hypertension. The new hemodynamic definition for pulmonary hypertension emphasize mean pulmonary artery pressure more than 20 and PVR more than 2 would a strategy by which to capture patient earlier in the disease. Some clinical groups are exclusive to specific hemodynamic categories. For example, pulmonary hypertension is the only observed in patient with isolated precapillary pulmonary hypertension and elevated pulmonary artery pressure wedge pressure, as measured pulmonary venous hypertension is reserved for patient with left heart disease. Patient with exertional dyspnea, preserved LV function and normal resting PAWP refer for exercise invasive right heart catheterization in whom mean pulmonary artery pressure divided by cardiac output slope is more than 3 mm of Hg per liter per minute represent an emerging clinical syndrome characterized by abnormal pulmonary vascular response to exercise. This is according to 2023 European Society of Cardiology and European Respiratory Society. Pulmonary hypertension, they mentioned the mean pulmonary artery pressure more than 20, the typically clinical group all. The precapillary pulmonary hypertension is mean pulmonary artery pressure more than 20 mm of Hg and pulmonary vascular resistance more than 2 would PAWP less than 15. This is typically clinical group pulmonary arterial hypertension and pulmonary hypertension attributable to lung disease and chronic thromboembolic pulmonary hypertension. Combined precapillary and postcapillary, the mean pulmonary artery pressure more than 20 mm of Hg and PVR more than 2 would and PAWP more than 15. That left-sided heart disease, left-sided heart plus lung disease overlap. Isolated post-capillary pH, the mean pulmonary artery pressure is the same more than 20 mm of Hg, but PVR here less than 2 would, that is left heart disease. And exercise pulmonary hypertension, mean pulmonary artery pressure, the divided cardiac output slope between the rest and exercise more than 3 mm of Hg per liter per minute. Exertional dyspnea with preserved LV ejection fraction with normal resting PAWP. And hemodynamics parameter, systolic pulmonary artery pressure, normal value 15 to 30 mm of Hg, abnormal more than 30 or more than 40. Mean pulmonary artery pressure 9 to 16 is the normal, moderate more than 18, significant more than 25, exercise induced more than 30. Pulmonary vascular resistance, that is 60 to 120 dyne second centimeter to the power 5 and 1.1 to 1.4 wood unit. Mild more than 125 dyne and moderate more than 200 to 300 and severe more than 600 dyne seconds per centimeter uh, to the power 5. Others are index pulmonary vascular resistance, pulmonary to systemic vascular resistance index, transpulmonary gradient, and mean pulmonary to systemic pressure ratio and mean systemic to pulmonary pressure ratio. WHO classification pulmonary hypertension, pulmonary arterial hypertension, and pulmonary hypertension associated with the left heart disease, pulmonary hypertension associated with lung disease, pulmonary hypertension associated with the pulmonary artery obstruction, pulmonary hypertension with unclear and multifactorial mechanism. The very most common is pulmonary hypertension associated with the left heart disease. Idiopathic pulmonary precapillary pulmonary hypertension and combined pre and post capillary pulmonary hypertension. This is very common. And pulmonary hypertension associated with the lung disease, non-severe pulmonary hypertension and severe pulmonary hypertension. These are the common. Rest others are rare. Epidemiology of pulmonary hypertension, 39% shows like a idiopathic, and less more than 4% is familial. In between, the connective tissue disorder 15%, 11% congenital heart disease, portal hypertension 10%, 9.5% appetite suppressant, and 6% is HIV. Group 1 pH, this is the classifications that idiopathic pH, familial BMPR2 gene ALK1 unknown. Associated with the pH, connective tissue disorder, congenital heart disease, portal hypertension, HIV, drug, toxin, hereditary hemorrhagic telangiectasia, hemoglobinopathy, myeloproliferative disorder, splenectomy. Associated with the venous and capillary involvement, pulmonary veno-occlusive disorder, and pulmonary capillary hemangiomatosis, and persistent pulmonary hypertension of newborn. Group 2, that pulmonary hypertension due to left heart disease, systolic dysfunction, diastolic dysfunction, and valvular heart disease. Group 3, pulmonary hypertension associated with the lung disease or hypoxemia, chronic obstructive lung disease, interstitial lung disease, sleep disorder, alveolar hypoventilation, chronic exposure to high altitude, and developmental anomalies, abnormalities. Group 4, pulmonary hypertension due to chronic thrombotic and embolic disease, thromboembolic obstruction of proximal pulmonary artery disease, thromboembolic obstruction of distal pulmonary arteries. Group 5 is the miscellaneous sarcoidosis, histiocytosis X, lymphangiomatosis, compression of pulmonary vessels by adenopathy, tumor, fibrosing mediatitis, and thyroid disorder, glycogen storage disease. Pathogenesis, there are few pathogenesis. The pathogenesis of the pulmonary arterial hypertension, risk factor and associated condition, vascular injury, disease progression. The risk factor and associated condition, collagen vascular disease, congenital heart disease, portal hypertension, HIV, drug, toxin, and pregnancy. Susceptibility, abnormal BMPR2 gene and other genetic factor. Endothelial dysfunction, nitric oxide synthesis decrease, and decrease in the prostacyclin production, increase thromboxane production, increase endothelin 1 production. Vascular smooth muscle dysfunction, impaired voltage gated potassium channel, and disease progression, that loss of response, the short acting vasodilator trials. Here is another pathway, that is endothelin pathway, nitric oxide pathway, and prostacyclin pathway. Pre-pro-endothelin to pro-endothelin, endothelin receptor A, endothelin 1 receptor antagonist, and endothelin receptor B, vasoconstriction and proliferation. Nitric oxide pathway, L-arginine and L-citrulline nitric oxide. Here phosphodiesterase 5 inhibitors, that phosphodiesterase type 5 CGMP, and then exogenous nitric oxide, vasodilatation and antiproliferative. Arachid and prostacyclin pathway, that arachidonic acid to the prostaglandin I1, I2, that prostaglandin I2, that CMP, that prostacyclin derivative, vasodilatation and antiproliferative. The most common mechanism that could produce the pulmonary hypertension in cardiac surgery, patent foramen ovale. Pulmonary hypertension, that increase left ventricular end diastolic pressure. Left ventricular dysfunction, underlying pulmonary hypertension. Then pulmonary inflammation or ischemia, this is exacerbated. And then potamin administration, mitral patient prosthesis mismatch or post-op valvular dysfunction, hypoxia, hypercapnia, pulmonary emboli, increased right ventricular afterload, right ventricular dysfunction, positive pressure ventilation and mechanical compression of pulmonary vessel, mechanical compression of pulmonary vessel local thoracic and abdominal. Pulmonary hypertension in valvular heart disease, aortic stenosis, aortic regurgitation, mitral stenosis and mitral regurgitation. Aortic stenosis and aortic regurgitation indirect impact on LA pressure. LA pressure overload, LA volume overload. That diastolic dysfunction increase left ventricular end diastolic pressure, that increase LA pressure. Mitral stenosis and mitral regurgitation direct impact on the LA pressure, that increase LA volume overload, increase LA pressure. Then hemodynamic cascade decrease the LA compliance, backward pulmonary vein pressure, pathological changes in pulmonary vein and arteries, muscularization of arterioles, medial hypertrophy, neointimal formation, distal artery, increase in pulmonary vascular resistance, increase pre-ap pressure. Pulmonary hypertension, increase RV afterload, RV remodeling dysfunction, and then symptom right RV heart failure and increase cardiac mortality and morbidity. And there is the gas exchange impaired, alveolar capillary pathophysiological cascade, reversible alveolar capillary stress failure, neurohormonal activation, angiotensin 2, hypoxic and cytotoxic TNF alpha and endothelin 1 stimuli, impairment of endothelial permeability, extracellular matrix thickening, late phase pulmonary alveolar capillary remodeling. Now, pH associated with congenital heart disease. Why does pH occur in children? Pressure overload to LA, LV systolic diastolic dysfunction, MV or AV stenosis and regurgitation, pulmonary vein obstruction. Pulmonary blood flow, congenital heart disease with left to right shunt, pulmonary vascular resistance, pulmonary parenchymal disease, thromboembolic disease. Congenital heart disease associated with pulmonary artery hypertension. Pulmonary artery hypertension is a major acquired complication of congenital heart disease with left to right shunt. PH cause increased morbidity mortality. PH may prevent complete repair in those with advanced pulmonary vascular disease. 15 to 30% of congenital heart disease population is thought to develop at least transient pulmonary artery hypertension. Cause of congenital heart disease associated with PH, risk factor of pulmonary arterial hypertension in children with congenital heart disease, type of defect, high risk, moderate risk, and low risk. High risk truncus arteriosus, AV Carrel, TGA with VSD, almost 100% risk if untreated. Moderate VSD like Eisenmenger's syndrome if untreated, 3% when less than 1.5 centimeter, 50% when more than 1.5 centimeter, and patent ductus arteriosus, and low risk ASD, PA, PVR, pressure and flow of left to right shunt, and presence of associated non-cardiac syndrome, especially Down syndrome. When does congenital heart disease and pulmonary arterial hypertension develop? The age at which congenital heart lesions cause irreversible pulmonary vascular disease varies. Endothelial changes occur as early as 2 months after birth in some children with increased pulmonary blood flow. The type of the congenital heart disease matters. Combination of high pressure and high flow causes more rapid and severe remodeling. Clinical onset ranges from as early as 4 to 6 months in CAVC or truncus arteriosus to never in small ASD or VSD. The pulmonary vascular remodeling process is reversible in early stage of the disease. Eisenmenger syndrome, the most severe form congenital heart disease associated with pulmonary artery hypertension. CHD with initial large systemic to pulmonary shunt that induce progressive pulmonary vascular disease, and PAH with resultant reversal of shunt and central cyanosis. When shunt reversal occurs, symptoms include cyanosis, dyspnea, fatigue, dizziness, syncope, and poor exercise tolerance. Life expectancy is markedly reduced. Left to right shunt, increased pulmonary blood flow, endothelial dysfunction and vascular remodeling, smooth muscle cell proliferation, increase in extracellular matrix, intravascular thrombosis, increase PVR, inverted shunt right to left, and then cyanosis. Symptom of PH: dyspnea, fatigue, near syncope, chest pain, palpitation, lower extremities edema, and hoarseness of voice. Physical examination, that is clear lung, increase jugular venous pulse, prominent V wave if tricuspid regurgitation is present, fixed splitting of S2, left parasternal, left loud P2. Large pulsatile liver, cold extremities clubbing rare, and peripheral edema. Diagnostic workup: PH, suspected pulmonary hypertension, echocardiogram suggestive of pulmonary hypertension, yes and no. Yes, significant left heart disease adequate to explain the pulmonary hypertension, yes, that is the group 2 pulmonary hypertension. No, consider pulmonary function test, overnight oximetry, polysomnography, ventilation perfusion scan, ANA, RF, ANACA, HIV serology, liver function test. Underlying cause of pulmonary hypertension identified, yes or no. Yes, group 1 pH, group 3 pH, group 4 pH, or group 5. No, idiopathic pulmonary arterial hypertension confirmed with the right heart catheterizations. Echocardiogram suggestive of pulmonary hypertension, no. Low clinical suspicious for pulmonary hypertension, yes. Seek alternative cause of symptom, no. Consider exercise echocardiography or right heart catheterization. Always rule out chronic thromboembolic pulmonary hypertension, must be excluded in every cases of PAH. Potentially surgically remediable, VQ scan is preferred screening test, CT pulmonary angiography. Biomarker for pulmonary hypertension, no single biomarker is specific enough to definitely diagnose pulmonary hypertension. NT-proBNP is the most widely used biomarker for assessing right ventricular strain and risks in pulmonary arterial hypertension. Other for diagnosis and progression include inflammatory marker, interleukin 6, that growth factor, vascular endothelial growth factor, and GDF15 endothelial dysfunction marker, asymmetric dimethylarginine, angiopoietins, microRNA, and marker of vascular dysfunction remodeling such as circulating endothelial cell and endothelin 1. Biomarker based assessment, that is 6-minute walking test, and RDW, red cell distribution rate. Chest X-ray in pulmonary hypertension, large central pulmonary arteries, right ventricular hypertrophy, rapid attenuation of pulmonary vessel, clear lung fluid. ECG in PH, right axis deviation and R-wave, R-wave and S-wave ratio greater than 1 in lead V1, incomplete or complete RBV, increase P-wave amplitude in lead 2, P pulmonale due to the right atrial enlargement. Now monitoring of pulmonary hypertension. Effect of pulmonary hypertension on commonly measured hemodynamically parameter and intervention. CVP, that elevation large CV wave, elevated pulmonary artery pressure more than 25, normal or elevated pulmonary artery occlusion pressure necessary to differentiate between PH and PAH, elevated RV pressure, decreased cardiac output with thermodilution if severe TR, elevated pulse pressure variation and stroke volume variation in mechanically ventilated patient with RV dysfunction. Elevation in pulmonary hypertension do not necessarily imply fluid responsiveness. Mortality using thermodilution may be affected by severe TR leading to decreased cardiac output. Pulmonary hypertension effect on CVP, variable effect depending to large extent on the degree of tricuspid regurgitation, large CV wave. Although CVP may exceed a PaOP in pulmonary hypertension, it is not a predictor of fluid responsiveness. Do you still measure? Effect on pulmonary hypertension on PAC. Severe tricuspid regurgitation on PH make placement of pulmonary artery catheter is more difficult. Thermodilution method of determining cardiac output can be affected by severe tricuspid regurgitation. Passive leg rising test. Passive leg rising test as dynamic modality to evaluate the fluid responsiveness has limited value when RV is at the flat part of the Frank-Starling curve. Although if the right ventricle is at the early portion of the curve, there may be an increase in stroke volume and right ventricular function, and at least if the patient deteriorates, it may be reversible when using peripheral passive leg rising test. Preload does not predict with the volume responsiveness for given in the fixed amount of the fluid administration. The increase in stroke volume will be greater for patient with normal ventricular function. A represent here preload dependent and fluid responsiveness, then patient with impaired ventricular function, that is B preload independent and fluid non-responsiveness. However, static measurement of preload would be the same in the each patient. Echo features of pulmonary arterial hypertension. Echocardiogram finding the tricuspid regurgitation, right atrial and ventricular hypertrophy, flattening of intraventricular septum, small LV dimension, dilated PA, pericardial effusion, poor prognostic sign, RA pressure so high it impedes normal drainage from pericardium, do not drain usually, does not induce tamponade since RV under high pressure and non-collapsible. And echocardiographic criteria corresponding to the various level of likelihood that presence of pulmonary hypertension, that peak tricuspid jet velocity, estimated systolic pulmonary arterial pressure, other echo sign of pulmonary hypertension present, and the grade of evidence. The example, if RV morphology and function and systolic time intervals such as PAT or mid systolic deceleration of right ventricular ejection notching are suggestive of pulmonary hypertension, such diagnosis should be considered possible even if Doppler estimate of systolic pulmonary arterial pressure is within normal range. TRV more than 2.8 F per second correspondent to the TIPG 31 mm of Hg suggest pH except in elderly or very obese patient. Here is the transthoracic echocardiographic finding in pulmonary hypertension. A is a continuous wave Doppler imaging acquired from the apical four-chamber view in a patient with advanced stage PAH demonstrate severe tricuspid regurgitation. The velocity of the tricuspid regurgitation jet 4.8 in per second, well above the threshold 2.8, that suggests mild pulmonary hypertension corresponding to the estimate the right ventricular systolic pressure 98 mm of Hg and estimated pulmonary artery systolic pressure 108 mm of Hg. The B, from the same view, severe right ventricular and right atrial dilatation is noted. And in this picture C, the short axis, in the short axis two-chamber view, the interventricular septum imaged at the end systole is a flat, that is the D sign, indicative RV volume and pressure overload. And picture D is represent assessment of the RV systolic function accomplished by measuring the tricuspid annular plane of systolic excursion TAPC, which quantitates the apical displacement of the tricuspid annulus between diastole and systole measurement by M-mode echocardiography. In a patient with pH, TAPC less than 1.7 is prognostic for the adverse outcome. LV indicates the left ventricles here. The progression of the RV dysfunction in PH, thin RV, healthy pulmonary artery endothelium, thin walled relaxed pulmonary arteries and large capillary network, normal cardiac output, normal pulmonary vascular resistance, normal perfusion. The number 2 picture here is the thin RV, healthy PA endothelium, thin walled relaxed pulmonary arteries and large capillary network. Normal cardiac output, normal pulmonary vascular resistance, normal perfusion. Thin RV, healthy pulmonary artery endothelium, thin walled relaxed pulmonary arteries and large capillary network. Normal cardiac output, normal pulmonary vascular resistance and normal perfusions. Right heart catheterization, that RA less than 6 mm of Hg, RV pressure is 30 to 30 by 6 and pulmonary artery 30 by 12 and PCWP less than 12. Pulmonary vascular resistance and cardiac output by Fick equation, that AV oxygen difference is 1.34 into hemoglobin concentration into SaO2 minus SvO2. Then Fick cardiac output, estimate the oxygen consumption divided by 10 arteriovenous oxygen difference. And here is the calculation of the pulmonary vascular resistance, that 80 into mean pulmonary artery pressure mm of Hg minus left atrial pressure divided by pulmonary blood flow. Mean pulmonary arterial pressure at rest more than 25, exercise more than 30, wedge pressure less than 15, pulmonary vascular resistance more than 240 dyne centimeters seconds. And these are the grading of the pulmonary arterial hypertension: systolic, diastolic and mean. Grade 1, that is the mild, grade 2 moderate, grade 3 severe, grade 4 is the systemic or supra-systemic. That grade 1 mild is a 30 to 50 systolic pressure, diastolic 20 to 25, mean is more than 30. And more severe, that is a grade 3, 70 to 110, 36 to 45 and more than 50 is the mean. Role of echo in diagnosis of pulmonary hypertension and assessment of PARV hemodynamics. The estimating pulmonary artery pressure by echocardiography, the systolic pressure, that 4 into peak TR velocity square plus right atrial pressure, where the peak TR velocity is the highest velocity of tricuspid regurgitation measured by the Doppler echocardiography, and right atrial pressure is estimate the based on the size of the inferior vena cava. This formula is derived from the Bernoulli equation and used when there is no pulmonary stenosis or right ventricular outflow tract obstruction. Estimated diastolic pulmonary arterial pressure involve echocardiographic, that is the 4 into n diastolic pulmonary velocity square plus right atrial pressure. The formula uses modified Bernoulli equation to convert the velocity of pulmonary regurgitation jet at the end of diastole into pressure gradient, which is then added to the measured right atrial pressure to get the pulmonary artery diastolic pressure. Pulmonary artery mean and diastolic pressure. This is the pH, and then this is the severe pH, where we can see the W, this notch. The pulmonary acceleration time, a non-invasive measurement from echocardiogram that estimate pulmonary artery pressure and pulmonary vascular resistance. It is the time of the onset pulmonary artery blood flow to the peak velocity. A shorter T indicate the higher pulmonary artery pressure and resistance, suggesting the condition like pulmonary hypertension. Pulmonary arterial PA in pulmonary vascular disease. This is the chronic thromboembolic pulmonary hypertension before, and this is the same patient is after. Right atrial pressure estimate, IVC and hepatic vein. Right atrial pressure estimate should not be based on the arbitrary value, but rather based on the 2D and Doppler imaging, the IVC and hepatic vein. Hepatic vein more than 11 mm of Hg is abnormal. Right atrial pressure estimate, IVC and hepatic vein. American Society of Echocardiography recommend that 3 mm of Hg, IVC diameter less than 21 mm, more than 50% collapsibility. 8, that is IVC normal and diameter less than 50% collapsible. 15, IVC diameter more than 21 with 50% collapsible, and 20, IVC dilatation with less than 50% collapsible. Right atrial pressure estimate, hepatic vein flow, and pH. The systolic filling fraction, that is abnormal A wave is larger than the systolic A wave. This is the abnormal and this normal. How should you define the mild, moderate, and severe pH? Not by RVSP, not by ratio of RVSP to systemic blood pressure. Define the pH severity, the degree of RV dilatation, RV dysfunction, RV pressure elevation, decrease in the cardiac index. Pulmonary vascular resistance, estimate that PVR using the equation that it is use the tricuspid regurgitation velocity and right ventricular outflow tract time velocity integral to provide a reasonably accurate estimate, especially for screening for pulmonary hypertension, though it may underestimate PVR at very high level. And PA is a W signs. Right ventricular upper load, it can be estimated by the stroke volume and pulse pressure by a cath or echocardiography, may be as important in pulmonary hypertension as resistance. Pulsatile component of pressure and flow, 30 to 50% power transferred from the RV to the pulmonary bed. Less than 1 is abnormal, and less than 0.8 ml per mm of Hg predict the mortality in pulmonary arterial hypertension patient. Indirect echocardiographic finding, that is mean pulmonary arterial pressure, RVOT acceleration time less than 90 milliseconds, flying W sign by a mode mid systolic notching, and dilated coronary sinus. Echocardiographic features of the PH, you can here see the RARV is the dilatations, and here is the D signs is the positive, and LV is the compressed due to the RV is dilated. RARV morphology in PH, RV dilatation, LV compressions, and flattening D-shaped septum, apex of the forming of the dilated RARV. And this is the RV size qualitative eyeball estimate. Quantitative estimate of the RV size, the length, mid diameter, and basal diameter, and RV area. Length is more than 86 and mid diameter more than 35, basal diameter more than 42, RV area more than 28. Measure indicate the dilatation. RV end diastolic diameter has been identified as the predictor of survival in patient with chronic pulmonary disease. Tips: measure at end diastole from an RV focus apical 4-chamber view. Optimize image to have maximum diameter without foreshortening the ventricles. RV measurement in 2D. RV end diastolic diameter has been identified as a predictor of survival in patient with chronic pulmonary disease. RV enlargement, RV D1 more than 42 and D2 is the more than 35 and length is 79. RV area more than 28 centimeter. The RVH is to RV, the thickness is more than 0.5 centimeter. The septal flattening and eccentric index, the pericardial effusion, a bad sign in PH associated with a greater disease severity, increased mortality risks, luckily reflect the high venous pressure and poor lymphatic drainage rather than the risks of cardiac tamponade. Echo measures of the RV function, TAPSE, simple, reproducible, represent longitudinal function, correlate well with radionuclide angiography in determining RV systolic function. Normal more than 20, TAPSE less than 18 has negative prognostic implications, angle and load dependent. In apical 4-chamber view, place the M mode cursor through the lateral tricuspid annulus, measure the excursion from the end diastole to the end systole, average over 3 beats of axis view, tend to overestimate TAPC as the apex forming of the RV. And echo-measure RV function, uh, tricuspid valve annular velocity, S prime by tissue Doppler index. Uh, Here is that MPI. It's a simple, sensitive, reproducible, good indicator of basal free wall function by tissue Doppler index. Several indicates of RV function can be obtained from a single cardiac cycle: peak velocity, isovolumic parameter, and TI index, angle dependent, relatively independent of the loading condition, correlate with RVEF by first pass radionuclide ventriculography. Normal is more than 10, normal MPI by TDI less than 0.55. RV index myocardial performance and global indicator of the systolic and diastolic function need the measurement of the two different cardiac cycle, tricuspid inflow and RV outflow by PW Doppler. Normal value below 0.4 means 0.28, relatively independent of the heart rate and loading condition. Prognostic in PH may get pseudo-normalized with the high right ventricular diastolic pressure and right atrial pressure. RV fractional changes calculations. The area changes is calculated as the end diastolic area minus end systolic area divided by end diastolic area into 100. Greater than equal to 35% is considered normal in adult, indicating the adequate right ventricular systolic function. DPDT, the rate of the rising LV and RV pressure, normal DPDT more than 400 mm of Hg per second. Why treat PH? Survival and prognosis of PH. Prognosis of the disease is very poor. The median survival of patient with IPH 2.8 years. Estimated survival rate are 68% at 1 year, 48% 3 years, 34% at 5 years. The estimated incident of PH among HIV infected patient 0.5%. PH found 7 to 29% patient with systemic sclerosis. Median survival of the patient who have scleroderma and PH is approx 1 year. This is the correlation. This is the correlations of 6-minute walk test with survival in PH, long distance group and short distance group. 6-minute walk distance strongly predictive of survival, less than 332 meter and 20% 3-year survival, more than 332 meter, 92% 3-year survival. And this is the PH risk score, WHO group 1 subgroup, demographic and comorbidities, NYHA and WHO class, functional class, vital signs, 6-minute walk test, NT-proBNP, echocardiography, pulmonary function test, right heart catheterizations. And reveal the registry. The PH risk score calculator calculate the risk score can range from 0 lowest risk to 22 is the highest risk. Poor prognostic factor, age more than 45 years, WHO functional class 3 or 4, failure to improve to lower WHO functional class during treatment, echocardiographic finding of pericardial effusion, large right atrial size, elevated right atrial pressure or septal shift during diastole, decreased pulmonary artery capacitance, stroke volume divided by the pulmonary arterial pressure, increase NT-proBNP level, prolonged QRS duration, hypocapnia, comorbid condition like COPD and diabetes. Who do we treat the PH? The treatment is based on NYHA, no symptom with ordinary physical activity, the 2 symptom with ordinary activity, slight limitation, symptom with the less than ordinary activity, marked limitation, and symptom with any activity or even at rest, that is class 4. Classes of therapy is diuretics, anticoagulant, digoxin, oxygen, pH specific therapy, surgical therapy, atrial septostomy, and lung transplant. These are the drug is approved for the pulmonary arterial hypertension, that is prostacyclin derivative, that epoprostenol, iliprost, treprostinil, and treprostinil and selexipag is a selective prostacyclin receptor agonist, and endothelin receptor bosentan, ambisentan, macitentan, phosphodiesterase 5 inhibitor, sildenafil, and tadalafil, and soluble guanyl cyclase stimulator, riociguat. Diuretics, the principally to treat the edema from right heart failure, may need combined classes thiazide and loop diuretics. Careful to avoid much preload reduction. Patient often require large dose of diuretics. Anticoagulant studies only show the benefit in IP, idiopathic pulmonary arterial hypertension patient based on improved survival. Other pH group not as clear, use then consider the expert opinion. Generally keep INR 2 to 2.5, thought to lessen in situ thrombosis. Oxygen formal assessment of the nocturnal and exertional oxygen need, minimize the added insult hypoxic vasoconstriction, keep oxygen saturation more than 90, may be impossible with large right to left shunt, exclude nocturnal desaturation, overnight oximetry, rule out concomitant obstructive sleep apnea and hypoventilation syndrome. Inhaled nitric oxide role is used pulmonary hypertension to act as a selective pulmonary vasodilator, relaxing blood vessels in the lung and improving blood flow and oxygenation. While it is standard part clinical practice for neonatal and pediatric pulmonary hypertension tool for acute vasoreactivity testing in adult, it used for the long-term treatment of adult PH is limited due to cost and technical challenges and potential for side effect like methemoglobinemia. How inhaled nitric oxide works? Selective vasodilator and rapid inactivation and antiproliferative effect. Selective vasodilatation is a potent vasodilator that preferentially relaxes the smooth muscle of the blood vessel in the lung, particularly those are well aerated. And rapid inactivation, it is rapidly inactivated by hemoglobin in bloodstream, preventing systemic effect on the rest of the body, avoiding problem like hypotension or ventilation perfusion mismatch. Antiproliferative effect, in addition to the vasodilatation, nitric oxide has antiproliferative action which help the suppress the growth cells and that thicken the blood vessels wall in pulmonary hypertensions. This is a vasoconstriction of the blood vessel, and after use the inhaled nitric oxide, the dilated of the blood vessels. Inhaled nitric oxide has several important clinical applications related pulmonary hypertension. Newborn that persistent pulmonary hypertension, inhalation nitric oxide help increase oxygenation and decrease need for extracorporeal membrane oxygenation and invasive life support treatment. Cardiac surgery, inhalation nitric oxide is used to treat acute pulmonary hypertensive crisis that can occur during after cardiac surgery. Study have shown it improve the hemodynamic and oxygenation for perioperative pulmonary hypertension. Vasoreactivity testing during cardiac catheterization procedure, a short-term dose inhalation nitric oxide can be used to the test capacity pulmonary vessel to dilate. A significant response inhalation nitric oxide can help predict patient response to other oral vasodilator therapy. And right heart failure help to decrease the afterload on the right ventricle, benefit in the patient experiencing the right heart failure due to pulmonary hypertension such following left ventricular assisted device insertion. Potential side effect, rebound pulmonary hypertension, methemoglobinemia, nitric nitrogen dioxide toxicity, and hypotension. A comparison of inhaled nitric oxide and milrinone for treatment of pulmonary hypertension in adult cardiac surgery. In their study, they concluded that treatment of the pulmonary hypertension in adult cardiac surgery patient with inhaled nitric oxide compared with the milrinone is associated with the lower heart rate, higher right ventricular ejection fraction, and lower requirement for treatment with vasopressor agent. Now next is the milrinone is the phosphodiesterase 3 inhibitor, used pulmonary hypertension for inotropic, improve the contractility and vasodilatory, widen the blood vessel effect, particularly in the context of heart failure, cardiac surgery, and neonatal persistent pulmonary hypertension. It works increasing intracellular cyclic AMP, which strengthening the heart muscle contraction, improve relaxation, dilate pulmonary blood vessel, while intravenous milrinone is common. Inhaled milrinone offer localized high concentration to reduce pulmonary artery pressure, especially after cardiopulmonary bypass. How milrinone is work? Phosphodiesterase 3 inhibitor. Milrinone block the enzyme that break down the cyclic AMP, increase cyclic AMP. Higher cyclic AMP level lead to the increased contractility, heart muscle pump more forcefully, improve the relaxation, heart muscle relax more efficiently after this beat, and vasodilatation, smooth muscle in blood vessel wall relax, causing them widen. This is the mechanism, the cardiac effect, that increase cardiac output and vascular resistance, decrease the right atrial pressure, decrease sinus pressure, decrease the CSF pressure, and reflects the sympatholysis, direct vasodilatory effect, and increase pulsability. That is increase pulse pressure, increase flow through the collateral vessel, increase wall shear stress, induce vasodilatation, and upward rightward shift of the autoregulation plateau. Route intravenous and inhalation, clinical application, cardiac surgery, heart failure, heart transplant, and persistent pulmonary hypertension of the newborn. Milrinone is often given after CVP to decrease the pulmonary artery pressure and support right ventricular function, especially when we have the bypass. And for heart failure, it can provide the cardiac support in patient with the chronic heart failure, particularly those associated with pulmonary hypertension. And heart transplant, IV bolus can use to test if the pulmonary hypertension is reversible, which is crucial for the heart transplant candidate. Benefit and challenges: improve the cardiac output, reduce pulmonary vascular resistance, and support the right ventricular function. Challenging: a major disadvantage of the IV administration is the risk of systemic hypotension. Study of hemodynamic effect: inhaled milrinone versus inhaled nitroglycerin on mechanically ventilated patient with pulmonary hypertension after mitral valve replacement surgery. In their study, they concluded that both milrinone and nitroglycerin inhalation proved to be the effective pulmonary vasodilator that avoids systemic adverse effect. Nitroglycerin inhalation is a less expensive, specially obtained drug that can serve as inhaled pulmonary vasodilator in patient with mitral valve disease and PH following mitral valve replacement surgery. And other drugs is a calcium channel blocker. The diltiazem nifedipine is preferred. Titrate up to maximum tolerated dose. Systemic hypertension may prohibit use. Only 50% patient maintain the response to the calcium channel blocker. And endothelin receptor antagonist, bosentan, ambisentan, and sitaxetan, and macitentan, both show the improvement, the 6-minute walking distance test and time to clinical worsening. Monthly transaminase monitoring required for the both, and this annual cost is very high. Potentially for the serious liver injury, and oral dose initiated 62.5 mg BD for first 4 weeks, then increase maintenance 125 mg BD thereafter. Initiation maintenance dose 62.5 mg BD recommended for the patient with the 12 years of age with body weight more than 40 kg. No dose adjustment is required in patient with renal impairment, and no predetermined dose adjustment required for concomitant warfarin administration. Phosphodiesterase 5 inhibitor, nitric oxide exert the effect through the CGMP pathway and is modulated by the phosphodiesterase. phosphodiesterase 5 located in the walls of the blood vessels, and pulmonary vasculature predominantly has phosphodiesterase 5. This is the dose. Initially sildenafil dosing, the 0.5 mg per kg orally every 8 hours, and titrate up to 2 mg per kg orally every 6 hours, or to need whichever is less over 2 weeks. Maximum dosing 8 mg per kg per day orally. Two consecutive echocardiography investigation showing the resolution of pH, discontinuation of regimen. Sildenafil citrate therapy for pulmonary artery hypertension. Uh, it is a super study group. In their conclusion, that sildenafil improve exercise capacity, WHO functional class, and hemodynamic in patient with symptomatic pulmonary arterial hypertension. Prostacyclin analog, epoprostenol and treprostinil and iloprost benefit vasodilatation, platelet inhibition, antiproliferative effect, inotropic effect. Epoprostenol, the first pH specific therapy available in the mid 1990s. The lack of acute vasodilator response does not correlate well with the epoprostenol unresponsiveness, very short half-life 2 minutes, and delivered via continuous infusions. Side effect: headache, jaw pain, flashing, diarrhea, nausea, vomiting, flu-like symptom, anxiety, nervousness, complex daily preparation, and individual dosing, catheter complication, dislodgement, malfunction, catastrophic deterioration, embolization, and infections. Treprostinil, this is hemodynamic improvement and 6-minute walk distance improvement, no side pain, risks of catheter-related bloodstream infection and emboli phenomena, recent concern about increased gram-negative bloodstream infections. And ileoprost, that inhaled prostacyclin, administered 6 to 9 times daily via the special nebulizer, and reported risks of morning syncope. Improvement: 6-minute walking distance and functional class and hemodynamic observed. Safety and study effect: potentially for increased hypotensive effect, anti-hypertensive, increased risks of bleeding, especially with co-administration anticoagulant and flushing, increased cough, headache, insomnia, nausea, vomiting, flu-like syndrome, increased liver enzyme. And guanylate cyclostimulant, that is the gut stimulator of the nitric oxide receptor, dual mode action. They increase the sensitivity of guanylate cyclostimulant to endogenous nitric oxide, directly stimulate the receptor to mimic the action of nitric oxide. And this has also reported the benefit in patient with inoperable and persistent chronic thromboembolic pulmonary hypertension. And this is the newer drug for pulmonary hypertension, that is a sotatercept. This is the phase 3 trial, the treatment of the pulmonary arterial hypertensions. Severe pulmonary hypertension in weaning from the cardiopulmonary bypass. Right heart dysfunction following cardiopulmonary bypass, difficult to weaning from the CVP. Evaluation of the RV pressure waveform, and TEE, and visual assessment of the RV. And RV pressure waveform gradient more than 25, then RVOT obstruction, TE criteria, stop inotropic and fluid administration, and heart rate control. And RV pressure waveform no gradient, slope aspect, and oblique square root sign, that RV systolic dysfunction. Transesophageal echocardiography and 2D assessment, that right ventricular systolic dysfunction. Possible ischemia, no ischemia. Possible ischemia, promote RV perfusion, medical treatment, vasopressor, optimize preload, reduce afterload. Surgical treatment, that RCA, venous bypass and ventricular assisted device. And if it is a no ischemia, then reduce the RV afterload, optimize PaO2 and PaCO2, and inhaled nitric oxide, prostacyclin and milrinone, and intravenous milrinone. Improve RV contractility, intravenous IV milrinone and adrenaline. Weaning from the CVP, this is an unexpected pulmonary hypertension upon weaning from the cardiopulmonary bypass. in a 76 years old woman after aortic valve replacement. The CVP duration was 71 minutes. A significant increased pulmonary artery pressure in relation to the systemic arterial pressure was observed as patient was weaned from the CVP. No mechanically cause were found. And compass program, this is the largest randomized control trial in ph ever, the first morbidity and mortality trial assessing efficacy and safety of the combination of bosentan and sildenafil, comprehensive clinical trial program to lead the future management of ph. Failure medical therapy, consider arterial septostomy that improve left-sided filling and decrease right-sided pressure may serve as the bridge to transplant. Before atrial septostomy that elevated RV preload and high RV wall trace and LV was underfilling. After surgery, that decrease the RV preload and decrease wall trace, improve LV filling and increase cardiac output, decrease PaO2. Failure of the medical therapy, indication for lung transplant, New York Heart Association functional class 3 and 4, mean right atrial pressure more than 10, mean pulmonary arterial pressure more than 50 mm of He, failure to improve functionally despite medical therapy, rapid progressive disease. These are the clinical trials, various clinical trials for pulmonary hypertension related with the RV dysfunctions. Changing in this is the pre-anesthetic induction and post-anesthetic induction. The mean arterial pressure and mean pulmonary arterial pressure, mean arterial pressure and mean pulmonary arterial pressure ratios. The change of the mean arterial pressure and mean pulmonary arterial pressure and mean arterial pressure divided by the mean pulmonary arterial pressure ratio after the induction of anesthesia. 32 patients were preoperative pulmonary hypertension. No significant changes in that ratio was observed. P value was less than 0.05. And this is the hemodynamic and transesophageal echocardiographic evaluation. 46 years old woman scheduled for the aortic valve surgery despite of the normal pulmonary artery pressure 34/16 mm of Hg. PVRI is 286 dyne second centimeter. This patient had abnormal right ventricular diastolic filling pressure waveform characterized by the rapid upstroke. That A is the reduced systolic to the systolic to the diastolic, and D is the pulmonaries. That S and this D and B is the hepatic venous flow consistent left and right ventricular diastolic dysfunction. In addition, dilated atrium and ventricle were present without significant tricuspid regurgitation in mid-esophageal right ventricular view. The mean arterial pressure and mean pulmonary arterial pressure ratio 65/23, that is ratio is 2.8. And this is the incident of the pulmonary artery pressure, artery hypertension patient, vasoreactive, non-vasoreactive, that without vasoreactive, without chest pain, syncope, and WHO functional class 4 or other high risk finding. Initial therapy, oral calcium channel and antagonist therapy, and non-vasoreactive with chest pain, syncope, WHO functional 4 or other high risk finding. Initial therapy, IV or subcut, prostacyclin, ambisentan and tadalafil. And non-vasoreactive without chest pain, syncope, WHO functional class 4 and other high risk finding. Initial therapy, ambisentan plus tadalafil and macitentan and tadalafil. These are the approach of the management patient with incident pulmonary arterial hypertension. And ventilatory strategy, the ventilator strategy pulmonary hypertension are the focused on avoiding triggers like hypoxia, hypercarbia, maintaining adequate oxygenation with 100% oxygen, and managing ventilation to prevent the acidosis and minimize the PEEP to avoid increasing right ventricular afterload. This strategy aims to reduce the right ventricular workload, improve oxygen delivery, and support hemodynamics in patient with pH and particularly during critical care situation. The key principal ventilator management: avoid hypoxia, hypercarbia, minimize PEEP, manage volume status, optimize anesthetic management if applicable, and consider non-invasive ventilations. The specific consideration: pulmonary hypertension patient, acute pulmonary hypertension crisis. In a crisis, moderate hyperventilation may be necessary to correct the respiratory acidosis. Right ventricular dysfunction: the pulmonary hypertension puts significant strain on the right ventricle. Ventilator strategies should aim to reduce this workload by optimizing oxygenation and ventilation while carefully managing the positive pressure. Underlying cause: the specific ventilation strategy may vary depending on underlying cause, pulmonary hypertension, and patient overall hemodynamic stability. Following the response to the therapy: 6-minute walk test, echocardiogram, right heart catheterization, NT-proBNP, functional class, prognostic parameter, and determining the risks in PH, the low risk group and high risk, and determinant of the risks. Echocardiography: minimal RV dysfunction in the lower risk group and pericardial effusion, significant RV enlargement dysfunction, RA enlargement, and TAPC is ESC guideline. The hemodynamic: right atrial pressure less than 10, cardiac index more than 2.5, and in the lower risk group, and higher risk group, right atrial pressure more than 20 and cardiac index less than 2.0. And NT-proBNP lower risk group is minimally elevated, but in case of the high risk group there is uh, significantly elevated. And WHO classification: lower risk group 2 and 3, and higher risk group is the 4. And 6-minute walk distance is the longer, more 400 longer, more than 400 meters, and in higher risk group shorter, less than 300 meters. And follow up the patient with PH ESC guideline, the clinical assessment, and WHO functional classification, and ECG, 6-minute walking test, NT-proBNP, cardiopulmonary exercise testing, echocardiography, and right heart catheterization. Thank you.
Yeah, thank you, Dr. Abhijit, for detailed discussion. So you have covered most of the thing. It's a very long topic. So anybody has any questions? So Abhijit, in your practice, in echocardiography, a lot of indicators are there in assessing the pulmonary hypertension. So, what are
Yes.
the common echocardiographic parameters you used to do at your center, or you suggest?
Sir, first we see that RV diameters, that are RA RV diameters, whether it is enlarged or not. This is the one thing. Another, we measure the pulmonary arterial systolic pressure, and we also measure the TAPC, and we also do the tissue Doppler, that is the S prime, sir.
Okay. So these are the common. A lot of new additional indicators have come up, but these are the common one. And among the inhalational agents for pulmonary vasodilation,
Hmm.
so what are the common inhalational agents you have been using or you have seen the people using?
Sir, we actually use the isoflurane.
No, for specifically for pulmonary vasodilator, like inhaled nitric oxide.
Oh, inhaled nitric oxide
Glucose,
and inhaled inhalation, that milrinone, sir, and
Malreno, you have
uh,
used?
milrinone pop, sir, and
Okay,
yeah, and sir, actually, I did not use that inhalation nitric oxide, sir. So
okay,
what I do, if the suspected case of the pulmonary hypertension, what I do that I stop the nitric oxide and increase the oxygen in the 100% to keep that oxygen saturation more than 90%, sir.
okay, okay. A lot of new drugs and now the drug and pulmonary vasodilators are available. Previously, people used to struggle a lot with the pulmonary hypertension, but gradually new drugs are coming up, and inhaled nitric oxide is gradually uh, available at most centers. So management is a bit easier than before, but still it's a very complex situation. So thank you for a detailed discussion. So thank you very much. And all the
Thank you.
participants, thank you everyone for joining.
Thank you, sir.
Welcome.